Undertegnede og Otto Kernberg fra den 9. norske psykologikongressen i 2012, der temaet var narsissisme og antisosial atferd.
For approximately 1 hour and leave time for some discussion. The subject of my presentation is an overview of the psychopathology of pathological narcissism, the narcissistic personality disorder. Can you hear me well? It's not too loud. It's about right? Okay. I would like to first give you a brief overview of the general clinical picture of the personality, of the narcissistic personality disorder, then describe degrees of severity of this personality disorder and special forms that this illness takes, and talk a little about the underlying psychological structure that are behind the manifest symptoms of these patients. Then I'll make some comments about prognosis, and I also want to touch base regarding the complication of antisocial behavior and the differential diagnosis of antisocial behavior, which is very important practically and is a territory of forensic psychiatry and psychology and clinical psychiatry and psychology at the same time. And if there's some time left at the end, I will tell you where we are regarding the forthcoming DSM-5 system of classification. I will only be able to talk very briefly about this, although in itself it's an interesting subject. The narcissistic personality disorder, general descriptive features. They can be classified into 3 major issues. 1, abnormality of the experience of the self. 2, abnormality of the relationship with significant others. And 3, abnormality of the internal value system. Self, relation with others, value systems. And in addition to this, a particular state of, a chronic state of feeling, a kind of a chronic state of self that is practically important, although it's quite logically related to the others. Abnormality of the self-experience. Basically, these patients have a sense of grandiosity, an excessive self-centeredness, an over-dependency at the same time of admiration from others. They think they are great, but they need others to confirm the greatness all the time. They have fantasies of success, superiority, grandiosity that are an important aspect of their daily life. They try to avoid realities contrary to such fantasies and expectations. And then, strangely enough, they have brief periods of terrible insecurity where all of this breaks down and it is almost a panicky sense of inferiority against which the upsurge of grandiosity protects them. Second, their relations with significant others. The main aspect of that relation is a deep feeling of envy. And it is interesting that this is not mentioned in the official classification of DSM-3, DSM-4, and even DSM-5. It is one symptom of the general classification of personality disorders, which is highly problematic. It's a political document, not a scientific one. This is true for DSM-3, for DSM-4, for DSM-5, hopefully not for DSM-6, but I don't know. I'm saying this with conviction and lots of information, so that we don't idealize what comes from the United States. Although it sounds very scientific, sometimes you look into this and the scientific basis is less powerful than it looks. So, a central aspect of the relation with significant others is intense envy. Envy, both conscious and unconscious, in the sense that there are defensive mechanisms going on against being controlled by excessive envy. Envy is a general human experience. We all experience envy. We all want to be superior and want to triumph. But for these patients, it is an overwhelming demand. It is an essential aspect of their life which makes them clearly different from the ordinary suffering that we all have of this kind of feelings. They show in their behavior greediness and exploitiveness of others, a tendency to devalue others, a depreciatory, devaluative tendency that precisely protects them against envy. Others have something, they don't have it. If they say it's not good, they feel better about the situation. They have a strange incapacity to depend on others, which is very reasonable, because to really depend on somebody means you value somebody else on whom you depend. But they can't do that, because that would put them into a position of inferiority. So to protect their sense of superiority and autonomy and independence, they have a deep difficulty to depend, and that shows in psychotherapeutic treatment. They have a lack of capacity for empathy. They are even highly intelligent and knowledgeable people. There are psychologists and psychiatrists and psychoanalysts with the narcissistic personality disorders and a remarkable lack of capacity for empathy. There is a shallowness of their capacity of human feelings, and at the same time a great difficulty to commit themselves to people as well as to purposes and goals. The main interest to protect and increase one's self-value, very difficult capacity for commitment to other goals. That's, in a nutshell, the relationship with significant others. Third, regarding the value system, one important characteristic is the persistence of childlike value systems rather than maturing of value systems. A wish to be admired for being beautiful, powerful, having great, beautiful, shining things that everybody admires. It is as if they wanted to be admired for their toys, rather than because of their personal value, their human depth, their knowledge, their understanding. So it is trying to be valued for the kind of values that are perfectly normal in childhood, but then are replaced by the adult reasons for which an adult wants to be appreciated by others. At the same time, they have a difficulty with the normal capacity of mourning. A strange, important relatives die, they don't feel anything about it. The incapacity to mourn is a general incapacity for the normal depressive feelings that are part of our adult capacity as well. I'm not talking about the pathology of depression, but normal mourning and sadness for the loss of good people, close people. Also have the difficulty of mourning or being sad over their own failures. When you fail, when something goes wrong, you do something wrong, you feel bad about it. This normal self-criticism is missing. And what happens is either they are remarkably callous and try to deny or project onto others the responsibility for areas in which they fail, or they go into deep, brief depressions. So instead of normal fluctuation of the self-esteem, sometimes we are happier with ourselves, sometimes we are not, they either are perfectly happy or go down into a severe mood swing. They have difficulty with the normal, sophisticated guilt feelings about inappropriate behavior. And if they avoid doing something antisocial, it's because they are afraid of being caught. They are ruled by shame, meaning being exposed for being inferior to others. There is a strong tendency to fear of being ashamed in replacement of feeling guilty. Again, a childlike exposure to being less perfect than they believe they were. They belong to a shame culture rather than a guilt culture. All this indicates failure in the normal system of internal ethical self-evaluation. What in psychoanalytic theory is called the superego. So there are superego deficits in these patients. And they show in the milder cases, in the symptoms that I mentioned to you. In the more severe cases, this shows in the combination of antisocial behavior, in other words, behavior that is frankly aggressive against other people, either of a passive or an aggressive kind, passive, parasitic, exploitive, or directly aggressive, hostile, demeaning, and to the degree of verbal behavioral violence. And therefore there is a type of them that shows an ego-syntonic aggression, and that can take various degrees, and under these conditions there is also an increased tendency to blame others for that aggression rather than accept any guilt feeling for one's own aggressive outbursts. And this tendency to attribute to other, to project, shows clinically, therefore, as hypersensitivity to others people's aggressive behavior, hyper-alertness, paranoid trends. So the combination in the more severe cases of antisocial behavior, egocentric aggression, and paranoid orientation leads to a very specific syndrome, which is the syndrome of malignant narcissism, characterized by narcissistic personality, egosynchronic aggression, paranoid tendencies, and antisocial behavior. And that may become extremely severe and lead into directly criminal activity. So we have a type of criminals who show the syndrome of malignant narcissism. It doesn't mean that all criminals have that, but it's a definite clinical constellation. And it's a constellation that requires the differential diagnosis with the antisocial personality disorder. And this brings me, I know you're going to have tomorrow a great presentation about the antisocial personality disorders, and I won't go into detail about the antisocial personality disorder, but the differential diagnosis is an area that is important precisely for this group of patients. And let me say immediately that the antisocial personality disorder proper, in the immense majority of cases, corresponds to patients who do have at the same time a narcissistic personality disorder, so that in some way one may describe the antisocial personality disorder as a narcissistic personality disorder with a total destruction or unavailability of internalized ethical systems of the superego. So what's the differential diagnosis between the syndrome of malignant narcissism and the antisocial personality proper? In the syndrome of malignant narcissism, there is still a capacity of some idealization. In addition to the idealization of self, which of course is very typical of our narcissistic personality, these patients have the capacity of idealizing some goal, some ideology with which they identify. An ideology, a religion, an ideology, a political commitment that becomes part of the personality, and that is idealized and melted with the personality. And at the same time, they also maintain the capacity of some relationship with significant others that they invest with, that they are committed to. So with all the superficiality of and their lack of general commitments to significant others, they still have a capacity to loyalty, and to a few selected others. Very typically, these are leaders of gangs or fundamentalist political parties who are defenders of radical, aggressive, destructive ideologies and behaviors, but maintain loyalty to a few followers. In contrast to the antisocial personality proper, where that capacity disappears completely. There is no capacity for investment or loyalty with anybody else, and no capacity either to investment of an ideology, a fundamentalist idea. There is only investment in one's own pleasure, and whatever special channeling that pleasure takes, pleasure in aggression or in acquisitions into a sexual area or direct murder, that rules life and is already devoid of any ideological superstructure. So you can make the differential diagnosis, and clinically this is part of a general task that we have whenever we see any patient with antisocial behavior to decide which is the level of severity of superego pathology, because that determines where you fit in diagnostically. The worst case, so let's talk briefly about, I have given you the basic description of the symptoms of the narcissistic personality, and now want to talk about differential diagnosis of antisocial behavior very briefly. And the most severe case is that of the antisocial personality proper, in which what is essential is the complete absence of any capacity for guilt feelings, complete absence of any concern for others and for themselves. These are patients who may also run into extraordinary risks and dangers because of a kind of a fearless exposure of themselves, so that in the antisocial personality, the grandiosity goes together with total lack of investment, but most importantly of concern and guilt, the incapacity of any superego function, such as concern about the future, a total immersion in the present, lack of concern for the future, lack of capacity to learn from experience. And so that in the antisocial personality, the indifference toward anybody else, even toward pets, if we have a pet, a dog, they may leave it for days without water or food, they just don't care. And there are, of course, two types: the aggressive one, with criminal behavior, of an aggressive, dangerous, threatening kind, and the passive, parasitic, the exploitive con men with chronic stealing, lying, falsifying documents, money, etc. So we divide the antisocial personalities in the passive parasitic and the antisocial and the aggressive. So this is the worst case scenario, and with any antisocial behavior, it's first of all important to rule that out, because the antisocial personality disorder has no treatment. And in contrast to the hopes until a few years ago that if one made the diagnosis in childhood and treated those children, one could prevent it, this is now questioned. The experts in that regard question the possibility whether the antisocial personality disorder, even in the early stages, once it has consolidated, can be treated. It's an open question. Second level is the syndrome of malignant narcissism, as I have described to you. Maintenance of some capacity for loyalty, some capacity for investment beyond that of one's own survival, some capacity for concern. You might be interested that that syndrome of malignant narcissism corresponds, for example, to some of the bloodthirsty dictators who are not psychopaths. Psychopaths, very difficult, take leadership of groups, political parties or nations. Studies of the personality of Hitler, for example, show clearly all the symptoms of the syndrome of malignant narcissism. The grandiosity, don't need to insist that, the paranoid attitude, the narcissistic grandiosity and the paranoid attitude, the intense aggression, and the antisocial behavior. The antisocial behavior in that those orders that he was afraid could be considered as against basic human tendency were never given in writing. The order of the elimination of the Jews was never written down, but given verbally through his immediate followers in various conferences. Not one document has been found about that. On the other hand, where the aggression could be rationalized in terms of political ideology, there was a written order. For example, before Stalingrad, he gave written orders that the entire population, men, women, and children, be killed. He said that is a system infiltrated by communism, and the entire city has to be destroyed. And that was given to the German generals who didn't question it and were willing to pursue in this way. Of course, it ended differently, as you know. So you have the aggression, the antisocial tendencies, and of course the aggression, the sadistic quality also showed more privately in that the attempt against his life by Stauffenberg and another group that led to the condemnation to death and hanging of the leaders of the conspiracy. The hanging was arranged so it would be slow and painful. It was carefully filmed, and Hitler watched those films for weeks. So you have, again, that combination, paranoia, aggression, narcissism. I don't go into detail about that when it comes to Hitler, but there was also the capacity for loyalty. To the almost end, he maintained the loyalty to Goering in spite of the total failure of that empty fool in every task that he got, and everybody else tried to convince Hitler to get rid of Goering. He wouldn't. And Hitler maintained his investment in several of close co-workers in spite of questionable behavior. Speer, his architect, who undermined the orders of Hitler in the last 6 months when Hitler decided to destroy everything in Germany that was lost because Germany didn't deserve to survive. It was not up to his ideals, and therefore with his death it should disappear. Speer operated against that, and Hitler knew it and did not have him shot, while on the other hand the brother-in-law of Hitler's mistress, Fegelein, who dared to get away from the bunker, Hitler had him shot just a few days before he committed suicide. So you can see still that element of capacity for loyalty, and of course the identification with the ideal that Germany is a superior race, etc., etc. I could give you similar information, for example, about Stalin, who also has been studied very carefully and had a very similar personality to Hitler with very similar traits. But this is not true for other dictators and horrible dictators. So it is very important to differentiate the political, military, historical function from the personality. So, antisocial personality, syndrome of malignant narcissism, then you have still less severe narcissistic personalities with antisocial behavior of a passive a parasitic type who have not bad prognosis and they are not dangerous. These are, I'll give you an example, a university professor whom I saw teaching in the areas of art and who would steal art books. He was an excellent thief and he looked so serious and respectable. He was not, for years he would rob all the specialized art bookstores of the city, and this was rationalized that all this wealthy bourgeois didn't understand anything about art. He understood about art. So, and this was a man who was loyal to his wife and children. He was a good citizen. He was just a specialized thief. So these are narcissistic personalities with antisocial. In one of our patients, in our research institute, we have been specializing in the degrees of severity of narcissistic personality disorders. So we have a huge number of patients who are in ordinary business, dishonest in a certain area, narcissistic personality, chronic dishonesty, but honest areas of life, commitments, and of course these are not as dangerous as those with the syndrome of malignant narcissism. With significant personality disorder, severe personality disorder, and antisocial behavior, but without showing a narcissistic personality disorder. A severe personality disorder of any other kind, but not narcissistic, has a better prognosis in terms of treatment. The next category is antisocial behavior at a level of a neurotic personality organization. I'm using the term neurotic personality organization in contrast to borderline personality organization. Borderline personality organization is equivalent to severe personality disorder with the syndrome of identity diffusion, lack of integration of the self-concept, lack of integration of the concept of significant others. Neurotic personality disorders are less severe, milder patients with a good integration of the self-concept, a good integration of the concept of significant others. And these are patients with obsessive-compulsive personality disorder, depressive masochistic personality disorder, hysterical personality disorder, in contrast to the patients with borderline personality organization who are the severe ones, schizoid, schizotypal, borderline, narcissistic, and of course the antisocial, the most severe of all personality disorders. In those milder personality disorders at a neurotic level, you may find antisocial behavior as a specific symptom. For example, we had a biological scientist who would falsify the results of her tests, of her experiments, and then she would review her experiments to show that the results, the false results, didn't stand. It was a compulsive symptom. One physician in our medical center would steal magazines, pencils, little objects from the shop in the hospital and was caught. And so we examined him, and he had an obsessive-compulsive personality disorder, and it was a specific symptom. He stole meaningless little things. This is very similar to shoplifting as a symptom of adolescent girls, particularly in the United States. I don't know whether this is fashionable here, but it is a frequent symptom in patients who then neither before nor afterwards show antisocial behavior. So this has very good prognosis with treatment. And then you have antisocial behavior as part of the adaptation to an antisocial subgroup, the so-called dissocial disorders in the British literature. These are youngsters with antisocial behavior. You take them out of the environment and they do great. And at last you have people who steal out of hunger and poverty and extreme conditions and have no kind of psychopathology. There is a social psychopathology, if you want to, but not a personality disorder. I hope I've given you the basic criteria of differential diagnosis. This is extremely helpful in practice, and of course, in forensic psychiatry, it becomes very important. I know everybody in Norway is concerned with the Breivik case, and I haven't studied the Breivik case, but I would say that the criteria that one would apply are the clearly severe, extremely severe criminal antisocial behavior. No doubt about that. So, what is the worst case scenario? Now, there are two worst case conditions than those that I mentioned. One is antisocial behavior as part of a chronic psychotic illness, a chronic schizophrenic illness with delusions and hallucinations. There's no doubt that we have a chronic psychosis. There are manifest delusions, hallucinations, and total disorganizations of language, behavior, affect, thoughts, no doubt about that. Then there exists a category that was described by Guttmacher in the United States, 1954, and has been strangely ignored, although we see all the time such cases, which is pseudo-psychopathic schizophrenia, a diagnosis which has fallen into oblivion, although clinically we still see these cases. These are patients who are psychotic, have severe and crazy antisocial behavior. They are clearly psychotic. You give them atypical antipsychotic. You treat them psychopharmacologically. The psychosis clear up, and they remain as antisocial personality disorder. You don't know what's worse. So we have an entire unit with these patients accumulated throughout time. So this is a very difficult category, and of course you can make the diagnosis relatively easy if you catch them while they are psychotic. The problem is after they are cleared, you have to observe what happens then. Does the person change into the normal behavior, or latent schizophrenia, whatever, or into an antisocial personality? So it is very important in patients with severe antisocial behavior who are clearly psychotic, a long period of observation once they're out of the psychosis. So those most severe categories, if you wish, you can add them: psychosis, pseudopsychopathic schizophrenia, antisocial personality, syndrome of malignant narcissism, narcissistic personality with parasitic antisocial behavior, other personality disorders with antisocial behavior, neurotic personality with antisocial behavior, dissocial reaction, normal antisocial behavior. This is, in a nutshell, the sequence. Now, next subject, levels of severity of the narcissistic personality disorder. At the highest level, you have patients who function extremely well. They seem, very often these are people with particular capacity and talent that permit them to get into superior position in politics, in industry, in religion, in art, in science, and they function very well, except they have difficulty in their intimate life, chronic couple therapies, chronic couple difficulties, difficulty commit themselves to intimate relationships, sexual promiscuity, or else they have chronic problems with co-workers, a kind of arrogant, grandiose attitude that creates problems for them, difficulties in their social life, they lose their friends because of their controlling and superior and lack of subtle tact in their social behavior. It is therefore very important in all patients where we suspect a personality disorder to carefully evaluate sexual life, love and sex, professional life, work and profession, social life, family, friendships, creativity, and study how the patient functions in those areas. I must confess to you that very often in the United States, I see in consultation patients where all kind of symptoms are described at their past and what happened in their childhood, in their infancy, and the family, everything from the past. The grandfather was a immigrant from Russia, a railroad engineer, and no information about the present-day functioning in love and sex, work and profession, social life and creativity. And these are the most important informations you need to make the diagnosis of all personality disorders and their severity. And I'm saying this here, if this is obvious to all of you, forgive me. In the United States, it's not obvious, it has to be said. So, the highest level function relatively well, except subtle chronic, but very often they don't come to treatment except if they have a minor symptom. Second level, there are significant problems at work that interfere with productivity, with promotion, significant problems in the emotional life. Here you have the typical patients who can't maintain love relationships, who show sexual promiscuity or great instability in their love relations, difficulties in their social life and creativity. These patients very often don't come to treatment before their 40s or 50s, because in their 20s and 30s they still manage, they are just struggling to progress at work, and they haven't committed themselves to a stable relationship and to have a family. And it seems they are still within the realm of normal, but then they realize that they are stuck, severely stuck, and the grandiosity suffers, and they start getting depressed because of chronic failure, and sometimes in their 40s and 50s, then this disappointment, the sense of failure, leads them into treatment. These have, in general, relative good prognosis for treatment, except if there is too much infiltration by aggression, when of course the symptoms become more severe, the deterioration of the internal value system is more severe, the capacity for commit themselves to a treatment process becomes more severe, so difficulties increase. And